is common sense too much to ask? And then where the consequences get left in the past? Is it just bad habits of a typical script? Is it all big plans and a hit and a miss? Can I say my influence because by design? Or the science and cigarettes my compromise? I don't know, but I'm blaming everyone else, just as long as I never put the blame on myself. 'Cause I know I wasted way too many times, living way too many lives. How can this be my fault? I'm always right.
Hello and welcome, this is your Brain on Drugs, and this is the Punk Rock Psychiatrist. So, today, I don't think this is going to be a very long episode. It is entitled Psychogenomic Testing. I only have 3 slides on my PowerPoint that I'm going through on this topic. So, many of you may be wondering, what is psychogenomic testing? It's also known as pharmacogenetic testing, and I'm going to have to give a little bit of a background on my personal background on this topic. So I first heard about this testing when I was doing my child psychiatry rotation as a third-year resident in psychiatry, and I remember my staff saying to me, I mentioned, hey, they brought this thing, this paperwork with this genetic testing stuff, like, what is this? And he was like, oh yeah, there's these like unscrupulous companies out there that are basically like saying, give us your money and we'll tell you what drugs will work for you. And then they come and bring that to the doctor and say, hey, can you prescribe me this medication? I was told by this printout that this is what's going to work for me. And he said basically that this was mostly nonsense. I also learned in that same clinic, someone had a scan. It was like a SPEC scan or something like that. Some sort of brain scan that tells them, what disorders they have and what meds that they need to take. And, a background on just this in general. I mean, when you think about psychiatry as a specialty of medicine, we don't really have any good tests for our disorders. You look at every other specialty of medicine, they may have radiology, different MRIs or X-rays or CT scans that help them out, even like PET scans. I mean, all sorts of different scans. We don't have that. When I use these, I'm using them to rule out non-psychiatric problems. So, say I might order an MRI because I'm concerned that someone may have some sort of maybe arteriovenous venous malformation, AVM, or brain tumor, or some sort of drainage problem of their cerebrospinal fluid. There's maybe some blockage there, or basically they're having some sort of psychiatric symptoms, and maybe there's a gross brain problem that if we do an MRI scan, we'll find out you don't actually have bipolar disorder or schizophrenia. So I'm not using the scans to diagnose my disorders. I'm using the scans to make sure that they don't have something else, and so that I'm not treating them for something they don't actually have. So I use them to rule out other conditions. Lab work, very similar in psychiatry. So I don't use lab work to diagnose or to really help me, with a few exceptions. I'm using them to, basically assess things that I could be causing, right? So I'm giving you an antipsychotic. I could be giving you diabetes or high cholesterol. So I need to keep an eye on that because I'm giving you a second generation antipsychotic. I'm giving you a medication for ADHD, which could raise your blood pressure. So I need to check your blood pressure. It's not that you have high blood pressure and I'm treating your high blood pressure. It's that I'm causing your high blood pressure, and that's why I'm checking. And the one exception that I can think of the top of my head where a lab might be helping, it's not with diagnosis. So it would be, say you're, not responding well to medication, and so I need to check your blood levels. That could be lithium, carbamazepine, antipsychotics. So it's more like to try and figure out if we have the right dose. valproic acid, we want to make sure you're in the therapeutic range. Not really using it to pick what treatment to give you. I'm not using it to figure out what you have. I'm using it to help me use the treatment. I've already decided what your diagnosis is. I've already decided what your treatment is. And now I have to monitor the treatment, essentially. So that's in psychiatry, that's mostly what we're using labs and radiology for. It's not for diagnosis and treatment as it is for almost every other specialty. And when you think about it, those are the two most important things when we're in medicine. I mean, someone comes in with a problem, we need to figure out what it is. And I don't have any labs or radiology to help me do that. Um, I just have labs and radiology to help me figure out what things that are not psychiatric, right, that they have. And I can't use them to treat either. I use them to assist with the treatment I've already done. So the bottom line here is we're guessing a lot of the time, right? Like we don't necessarily know what is going on, and we're assessing what the patient's telling us, what we're observing, and mostly just by we're not even like listening to heart and lungs, so we're not really even. Not only do we not um, get much use out of labs or imaging, we also don't get much use out of a physical exam. I with some exceptions, but for the most part, I'm not going to be able to do a physical exam finding and then know what you have. If it's a psychiatric illness, it's more like I'm going to know what you might have that's not a psychiatric illness. Same with the other stuff. So wouldn't it be great if we had tests that could actually help me know what you have and what to do about it, right? And then along comes things like the spec scan and psychogenomic testing to say, hey, look, if you get this test, we'll tell you what you have and what treatment that you should get. And so long intro, but like that's kind of where this is coming from. And I think it's easy to take shots at psychiatry because it's like, oh, they're just, doing this bad stuff to people and stuff like that. And it's like, no one can really prove that what I've determined your disease is not your disease. We have really no way of doing that. It's literally my opinion based on the way I assess your symptoms. And you may say, oh, well, we have the DSM, you have to have these criteria. And it's like, well, who decides whether you meet this criteria or not? You know, if you're not getting enough sleep, maybe it's for a good reason. Maybe I assessed it and I found out, oh, you have a crying baby at home and that's why you're not sleeping. You can't just say, oh, poor sleep. That's one symptom of depression. No, I mean, it's not as simple as that, right? And if you miss things like that, you may assess symptoms that aren't actually attributable to a psychiatric illness. And that's why it can make it quite difficult to diagnose these disorders. I mean, on the one hand, it could be quite easy. You could just open your DSM and ask a bunch of questions to a patient. And if you get enough yeses, then they've got that disorder. But that is not effective at all. Like, don't do that. If you're being taught to do that, don't do that. It's very complicated to assess if they meet criteria for each of these symptoms. You have to have a holistic kind of view of what their life is like and what's going on in their life, and try and account for why these things are happening to figure out like what are the really true symptoms that could be attributable to a psychiatric illness. I mean, and this is why the art of psychiatry it's really more of an art. And you got all these people trying to turn it into a science, and heck, wouldn't it be great if it was? Because it'd be a lot easier to get the right answers anyway, right? So like I said, in comes things like psychogenomic testing. So let's talk about what's on this test and what might be useful about it and what might not be useful about it. And I have to be honest with you, never ordered it. Never. I mean, I've seen a few. Um, I don't order these. I don't see a whole lot of utility. I can theoretically come up with a few things that might be useful, but honestly, those things have never really come up. So let's dig in. Um, First, I'm going to talk about three tests that I feel like could have some utility. So, I mean, remember, all these things are tested. So let's talk about three items you may see on one of these tests that may actually help you with treating a patient. First would be the enzymes, right? So our liver, our CYP P450 P450 enzymes. We're talking about 2D6, 2C19, things like that, right? We've talked about this before. These are the enzymes in our liver that break down the medications that patients are taking, and there's certain medications that can inhibit these enzymes or induce these enzymes, which basically make them work better or worse, which can raise or lower blood levels of drugs, take longer or quicker to clear them, which would interfere with how we want them to act. Well, I think I've mentioned this before. Some people kind of have their own internal inducing and inhibiting, in a way, it not exactly, but kind of in a way, they just have enzymes that work a bit better, and or work a bit worse. And so with the psychogenomic testing, right, so not all 2D6 enzymes were made the same. There are rapid metabolizers, ultra rapid, normal, intermediate, um, was it poor, right? So you've got all these different categories of 2D6, which the patient could have. And so with the psychogenomic testing, we can actually see which one they have. And so if we know they're a poor metabolizer of 2D6, then you may not want to prescribe them a medication that uses 2D6, right? And on the other hand, if they're ultra rapid, if they have an ultra rapid metabolizing 2D6, you might also not want to use it, right? Because if they metabolize 2D things that are processed by 2D6 extremely fast, that means it's going to clear the drug and we're not going to get any use from it. If they're a poor metabolizer, it means that maybe they're going to have a stronger effect than we want, kind of a similar effect to the inhibitors and inducers, right? So that might reveal, hey, don't use a drug that uses 2D6 or 2C19 or whichever one came up on the test. I'm going to go into detail on this a little bit more um, as we move on in the episode, but that would be potentially useful test. Um, but the way I kind of think of it is, did I really need the psychogenomic test to correct this problem, right? Say someone comes in and they've got a disorder where I'm wanting to start an antidepressant that we've discussed, let's say Prozac, right? Fluoxetine. It is metabolized by 2D6, and say they're a poor or rapid metabolizer. Doesn't matter which one. So something that might make Prozac work either not very well or make them sick, right? Well, I could order the fluoxetine and see what the result is, and if the result isn't good, I switch them to a different med. Okay? And maybe it's a good idea, if you're going to pick a second med, to pick one that's not processed by the same enzyme, just in case they are a poor or ultra rapid metabolizer of that enzyme. They probably won't be of a different one. All right? So that'd be like scenario one, like the way I do business. The other way would be that you get this test. But I'm not exactly sure how this works, right? So, what do I order the test before I order the fluoxetine? Because I might not want to order the fluoxetine. I might want to order something different if 2D6 is affected. So basically, they come in for an appointment, they walk out with nothing. I order a test. This is not a common test necessarily. It might take a while to get the results. It's not one that my hospital can run. My lab's not going to run this test. I'm going to have to mail this out somewhere else. Um, and not all of you work in facilities that have your own labs. I always have, because the military, we have our own labs. I'm going to have to wait. And then I get the result, and then I find out, oh, don't give them that medication. I'll give them this other one. Well, I mean, hasn't that just kind of taken the same amount of time anyway? Like in scenario one, I gave them the drug, found out that it didn't work, and switched them to something else. In scenario two, I gave them nothing, ordered a test, and then ordered something differently than what I may have ordered in the first place. In both scenarios, I kind of give them the same medication at the same time, right? Give them the second med or the first med, depending on which scenario it was, is the same med and it's given at about the same time. And they or this insurance company has had to pay for this test to get the same result. So, you know, I just don't, I don't see a huge utility there. And if you were going to go down this road, you'd have to order this test on every single patient because you're ordering it before you order the med, right? So don't you have to order it on every patient and before you treat everyone? I mean, isn't that a bit cumbersome and kind of a pain? I guess what you might want to consider doing with the test would be if you've got someone who's just like responding weirdly to everything that you give them, and you're just like, man, this is strange. They don't tolerate this. This one doesn't work at all. Like, what's going on here? Maybe there might be some utility to ordering one of these tests to kind of see, is this going to help me figure out what's going on? I mean, but is it, but at the same time, if I've got like three or four different enzyme pathways, and then I've got something like desvenlafaxine, which doesn't use any, which is active uh, and cleared in a different way, I could go to that med. Like I don't have to necessarily go to the test because if I'm thinking, oh, this could be like a very complicated enzyme issue, let's just give them something that would not be affected by any enzymes. Rather than saying, I don't know what the heck's going on. Let's order this test and see if that helps me figure it out, and then probably do the same thing anyway. Right. So in all scenarios that I can personally like think of, I just can't. I mean, I can't think of a scenario where having this information is really going to save me that much time, and and it's certainly going to cost more because we're going to have to order it, and it's going to take some time. And here's the other thing, right? Like you may think, oh well, you got to the same drug at the same time, right? Well, let's have two patients, one that's got some 2d6 issues that the test is going to help us with, and one that doesn't. We give them both fluoxetine. One of them responds to it right away, and the other one, had the problem, and then we had to change it to another med. If we order the test, they both have to wait. The person who doesn't have the issue and the one that does. And most people won't have the issue. The vast majority will not. And so what, you're just going to make those patients wait for the smaller fraction of people that are going to have this issue? I mean, I I just don't, like I said, it's just not that useful of information for me. And I guess if the patient has it and they've already had the test and they bring this thing to you, and that's happened to me, I could see some utility there because it's like, well, I don't have to think about wasting money on this test. It already exists. I don't have to think about wasting time to wait for the test results to come back because I already have them. So if they already had the test, maybe then maybe then it has some utility. But I'm not yet convinced. So let's talk about another but potentially, like I said, if they already had it, it might be useful. So potentially that is at least something that could help guide your care. Next, let's talk about the HLA-B variants. So this is a gene that there are many different variants. We're talking about HLA-B, sometimes like star 5201, 5228. I don't know. There's a bunch of these, and there is an increased risk of Stevens-Johnson syndrome with certain HLA-B variants. Okay, we haven't talked about Stevens-Johnson syndrome yet because none of the medications that I've discussed thus far have a risk for it. It is a very dangerous skin condition. I think most people think about it in relation to lamotrigine, which is a mood stabilizer used for bipolar disorder. Also, it's an anticonvulsant used for seizures. Carbamazepine is another one. I believe one of its black box warnings may be about HLA-B variants with Stevens-Johnson syndrome. Um, and so I think we think about lamotrigine, but carbamazepine actually has that warning. Um, Also, an anticonvulsant and a mood stabilizer. When we don't use that often anymore, because it does have a lot of issues. We'll talk about that when we talk about bipolar disorder. Um, and then there's other medications, phenytoin, another anticonvulsant, allopurinol, a medication that's not used that often anymore for gout, antibiotics, non-steroidal anti-inflammatory drugs like ibuprofen and Tylenol. Those are the medications that I think about when I think about risk for Stevens-Johnson syndrome. I don't think about any of the antidepressants. Could lamotrigine be used as an antidepressant? Yes, it could be. You could use it for someone who doesn't have bipolar disorder and for depression. Um, and actually, I think that's a good idea. But we haven't talked about lamotrigine yet. But that's the one I think about. And so and also it's mostly, I think, if not exclusively, Asians, specifically East Asians and the Indian subcontinent. So if you have an Asian patient and you want to start them on one of these medications, you might consider getting psychogenomic testing, or just specifically find out what their HLA-B variant is and see if it's one of the ones that would cause a problem. Um, but I mean, like I said, Tylenol and NSAIDs are also on the list of this risk, and we certainly don't get HLA-B genotyping for giving those medications. But carbamazepine's got the black box warning. Lamotrigine's what do you think about? So if you've got an Asian patient, it might be something to consider if you're considering. And out of all these medications, the only one I'm really going to prescribe is lamotrigine. Um, and we'll talk about that a little bit later. So that's something that I think for the right patient, you might want the test, but maybe just that specific test. Do we need the entire battery of psychogenomic testing? Probably not. And then the last one that there is some evidence for would be the MTHFR. This is, I should have written this down. It's like methyl transfer something, or it's reductase, something like that. It's there's not a non insignificant portion of the population. I don't quote me, 10-15% perhaps, that have a variant of this. It has something to do with their folate, um, the process of folate in their body, and for this particular for these folks that have this issue, often giving L-methylfolate, which I have not talked about yet, but which is in our depression series. When I talk about supplements that are used to treat depression, L-methylfolate is one of those. So folate is a critical B vitamin that we need for very important cell functioning in our bodies. And those that have this variant, this MTHFR, that's not as effective as it should be, they have problems with folate. And so and having problems with folate can cause mood symptoms. So giving them L-methylfolate, it's a type of folate that is already like, it's what if you had the well functioning MTHFR enzyme, you would get something similar to this as a result. So you basically give them the thing that they're not able to make well on their own, and that may help with their mood as well as other cell function that could be important. So, and when we talk about L-methylfolate, specifically the people that benefit are these people, and that you could find this out from the psychogenomic test. So those are the three tests that I kind of see use for. The the CYP450 enzymes, the HLA-B variants for Stevens-Johnson syndrome risk, and then the MTHFR with the folate. So those are three that there is evidence that getting those tests could be of some assistance to you. Now, you know what these tests kind of propose is that they can pick the med for you. And often they will list this is the med that this patient should use. This this part is kind of nonsense. And I say kind of because basically if they've got the issue with 2D6, it will like not list fluoxetine or there's several. Oh, I'm just using that as an example. Several of the antidepressants are processed by 2D6. In fact, most of them. Lexapro or escitalopram, citalopram, or 2C19. Bupropion is 2D, sorry, 2B6 or 2B9. I can't remember off the top of my head, but most of them are 2D6. So it'll basically spit out. I don't know if it picks one of the ones that's not 2D6 or if it just lists them all. But I mean, it's not really picking a med for you. It's just basically saying that these are meds that are not affected by this enzyme, or this is a med that's not affected by the enzyme. Not that you couldn't use a different one, right? It's not. The test makes it sound like, oh, I've got this test that says that escitalopram will specifically help me with my um, type of depression that I have based on my genetics. No, that's not what it says. It says that basically you don't have an enzyme issue that would affect escitalopram. That doesn't mean escitalopram is going to work. It doesn't mean it's more likely to work for you. It doesn't mean that it's like going to be the drug for you. It just means that you don't have anything that would make it not work. Um, and that's not to say that there's not another medication that might also be the same case. So it's very disingenuous when they're like, oh, we're gonna pick the med for you. Yeah, that's not how this works, right? And like I said, you could pick a med and then just change it to one that's affected by a different enzyme and essentially do what the test did, right? So I don't buy this. Oh, we're gonna pick the med. Like, don't fall into this trap. I think this is a money making scheme. All right, but those are three tests that actually could have some use. Let's talk about ones that are proposed to have some use, but there is little to no evidence for it. Insufficient evidence for the benefit of the test. We'll say it that way. All right. So first will be the COMT gene, COMT, all caps. So COMT, it's an enzyme that metabolizes neurotransmitters, which are those are what we're affecting when we're using antidepressants. Um, that this could, I mean, it sounds reasonable if you've got certain variants of this that it might help with something, but there's just no evidence to suggest that knowing this information is going to be useful at all. So you see the COMT gene information on the sheet, it really doesn't help us with anything. And as I already mentioned, any test that recommends a medication, that's just garbage. It's garbage. I mean, they're basically just leaving meds off the list that are affected by some enzyme metabolism issue that the patient has. That's all it's doing. Um, the, it's I feel like it gives false hope to the patient to say, "Oh, this is the med for you," So that's not useful. And then this other one, SLC6A4. So this gene is a serotonin transporter polymorphism. Okay, gene. So, I don't know if you're all familiar with this, but so people that have a history of major stressors and a short allele gene versus a long allele gene of this. So alleles are essentially the piece of DNA that the gene is on, of this SLC6A4, and the short allele gene types are SS or SL, and L being long. So if you're SL, so one of each, that's still considered, you've still got the short allele gene in there, and the long allele gene is LL, right? So basically what it says is if you have a history of major stressors and short allele genes versus long allele genes, you're more vulnerable to depression. So that the short allele gene makes you more vulnerable to depression. All right. And then those with the LL, or the long type, they have more serotonin reuptake transporter pumps, which is right what the antidepressants are inhibiting. Right. So having more of those seems like it's protective. Not really understanding the logic there, but anyway, the LLs have more cert pumps. Um, Previously, it was thought that gene type might predict response to medication, right? I mean, this is what I've said up to this point is all true. Those with the short type are more vulnerable versus the long type, and the long types do have more cert pumps. But how does this help us? Like, what can we do with this information? Well, it was thought that it might help predict the response to medication. However, with the evidence we have now, there's no evidence for this information helping us, right? So it was thought that the SL/LL may respond better to a higher doses of SSRIs, and SS may not respond well to SSRIs. And there's conflicting evidence about this, and the conclusion is inconclusive. So I'd say this test really is not useful. Maybe we'll find a way to make it useful in the future, figure out how to make it useful. But right now, as far as I know, the most up-to-date information, it's not going to help you pick a med. And then, so those are things that are going to be on your printout. And then here's something else that might be on there: the P-glycoprotein, or it's usually called PGP, and it's written with a capital P hyphen and a little g little p. So the PGP transporter gene. This is something I didn't learn about until like a few years ago. Not something that I learned about in med school or residency or any of that. I kind of found it on my own. So PGP, it's a transport protein at the blood-brain barrier. It removes unwanted chemicals, which includes medications, out of the central nervous system. That's what this thing does. So the P-glycoprotein is a protein on the blood-brain barrier that removes unwanted chemicals from the central nervous system. Some patients make less PGP, right? Studies show that patients given the test for PGP, that 72% get remission versus 28%. And so this is another test that may be useful. I'm not sure that this is actually on the standard psychogenomic testing that patients get, but that's pretty compelling. That if you get this test, that 72% versus 28% get remission. I mean, that seems pretty questionable to me, because wow, if I could improve remission from 28% to 72% simply by getting this test on patients, man, wouldn't I want to do that for everyone, right? So that seems almost too good to be true. All right, so the test may suggest higher doses for some medications. So desvenlafaxine, which normally we dose 50, maybe 100, doses up to 200, it may suggest. Citalopram is another one, it may suggest higher doses. Risperidone and paliperidone are also significantly affected. But then there's some antidepressants that are not affected. And remember how those are effective is that this PGP basically kicks them out of the brain. And we want them in the brain, right? Like that's where they're doing what they're doing to help with the depression. If this PGP is kicking them out, that's not a good thing, right? Um, but some antidepressants aren't affected at all. Bupropion, duloxetine, fluoxetine, mirtazapine. So it really doesn't matter what their genotype of with PGP is. If you give one of those meds, it's not affected. If they've got, if they've got less PGP or whatever, it may necessitate changing the dose of a medication. All right. And then, interestingly enough, I've talked about the CYP inhibitors and inducers. There are PGP inhibitors. So not just 2D6, 3A4, 1A2, all those good old P450 enzymes. There are actually PGP inhibitors. So fluoxetine, sertraline, paroxetine, and flufenazine. Not only, do some of those inhibit things like 2D6, they also inhibit PGP, which means that they're making PGP work less, which means PGP is going to do less of its job of removing things from the CNS, and that's going to affect meds, right? So, this is I think this is good information to know. You should be aware of PGP. This, I think I'd want to dig in a little deeper on this, like 72% versus 28% remission, because that sounds pretty impressive. But yeah, as far as I'm concerned, I don't really need this test to do what I do. And then lastly, I just kind of wanted to go over those, the CYP P450 enzyme phenotypes, just to kind of cover that, right? So remember I said you could be these are the phenotypes. So you could either be a poor metabolizer, intermediate, normal, rapid, or ultra rapid, right? And most people would probably be in the normal category. And as far as I'm aware, there's lots of these enzymes. You got 1A2, 3A4, 2D6, 2C9, 2C19. Those are the most common. There's like an E. One of them has an E in it. I forget what that one was called, 2E1 or something like that. But there actually, as far as I'm aware, only 3 of them do we have this poor and ultra rapid metabolizer options. The other ones, I guess, are just everyone's got the same type. They're all normal. Okay, so, and those 3 are 2C9, 2C19, and 2D6. So you could be poor, intermediate, or ultra rapid at any of those 3. And it depends a little bit on race. There's a correlation there. So I think with 2D6, you've got a lot of the white population are poor 2D6. So 7 to 10% of the white population versus 2 to 7% of the black population and 1 to 5% of the Asian population. Now, I mean, I find it amusing that, it's always kind of stated, oh, if you've got a white patient, think about this. But I'm thinking, okay, 7 to 10% of white people versus like 2 to 7% of black, or 1 to 5% of Asian. That's like not even twice as many, right? Like, do I really need to be thinking about this when I have a white patient? Because they're like a fraction more likely to have this issue. I think you can really get lost in the sauce there, right? Like, it just because someone's black doesn't mean that they can't be a poor metabolizer of 2D6. In fact, it's almost the same amount, just slightly less than white population. Okay. And then I think about and then when you look at intermediate, which is still less than normal, 51% of Asians are intermediate of 2D6, 30% of black, and only 1 to 2% of white. And so, I think that's meaningful. Okay, well, whites are more likely to be poor metabolizers, but Asians are more likely to be intermediate, which is still not great, right? And then ultra rapid, the numbers I have are 0.9 to 21% for Asian, 4.9% for black, and 1 to 5% for white. So, Asians are more likely to, not only they're more likely to be intermediate, they're more likely to be ultra rapid. So, is this knowing someone's race here really helping me out? And then with the 2C19, Asians are 18 to 23% likely to be poor, versus 1 to 5 for black and 2 to 5 for white. Of course, black and white can have this issue, but in this case, a lot more Asians do. And the breakdown is even further when you look at the subtype of Asian. So Japanese being 20.3%, Chinese 13.6, and Korean 13.7. So Japanese population being the most likely to be poor 2C19 enzyme functioning. Okay, so when you're thinking about the enzymes, those are the three enzymes that we think about the most. And with 2C9, it's really not that significant. I mean, look, poor 0.4% for Asians, 0% for Black, 1% for whites. That's very little. There's no ultra rapids. I've got no information on ultra rapids for intermediate, 3.5 Asian. And remember, intermediate's only slightly less than normal. 3.5% Asian, 13 Black, and 33 white. So with 2C9, and not a lot uses 2C9, bupropion does. So not a lot of concern there with 2C9. It's mostly 2D6 and 2C19. And so even when we're thinking about these enzymes, and of course we have medications we've discussed that don't use any of those enzymes. And if you use those, then you're not even necessarily, why would you get the test if you were going to order a med that wasn't even affected by something that would show up on the test, right? So I think that's why it's important to kind of know that information. So, you know, that's what I have to say about psychogenomic testing. I think a lot of people are interested in it, and I understand the interest. I think it can be very discomforting to not know what to do and kind of just be guessing, which is what we're doing. We're making like as good of an educated guess as we can, which is really all anyone is doing in medicine. But in psychiatry in particular, we're doing the guessing a lot more. So it's a lot more of a guess because we have very little to go on. We have so little, we don't have as much information. And so, oh man, wouldn't it be great if these tests were like gonna save us and like help us fix, help the patient get better faster or at all, like in many cases we can't help them at all. And if there was a test that could give us some sort of magic answer, that would be great. But when I think about a lot of the other stuff too, when you think about medicine in general, might they lean on these tests a little bit too heavily? Oh, we should get this test, we should get this test, we should get that test, when like 50 years ago they just did a really freaking good physical exam. I remember when I was in med school, they taught us all these physical exam things that no one ever uses anymore. Doctors used to have skills that they don't necessarily use anymore that got them the answers anyway without these fancy tests that we have now. And I wonder if psychiatry, could learn something here. Do we need all these fancy tests? Or is the art of psychiatry really knowing the patient, learning about them, and understanding the disorders? And, you know, if you have a test, I feel like something's lost there. You've lost this ability to do this physical exam finding or whatever it was. And now you basically just rely on this test that you don't really understand, but it kind of is like a computer just spits out the answer for you. And you don't really understand as much as you would have had you done it the old way. And so, I mean, I'm not saying that we need to go back to the old way, because a lot of the changes have been amazing. But at the same time, we've lost something. It's kind of like moving from using an abacus to, a counting machine to, computers, etc. Right? When you knew how to use those older systems, you probably understood the math and things like that a little bit better. Whereas now we just kind of put the information in there, it spits something out. Maybe we don't quite understand how it got there, what it means, or whatever, but we just take it for what it's worth and we move, right? I think knowing that background information could be helpful. So, you know, I think we want to have something to help us do our job better because we think it's going to help us help patients better. And I think that there's a lot of people out there touting these tests, and there might be some useful information to glean from them, but to me, I think it's kind of like when these people like talk to the ghosts of dead relatives, right? To throw a really out there tangential metaphor, right? They're like, "Oh, I'm talking to your dead father, and he's saying, 'Don't worry, I forgive you.'" You're giving comfort to the person, but you're just blowing smoke up their bum. You know what I mean? Like you didn't actually do that. You're just kind of giving them comfort. And I think patients, they want to get better. They want to be healed. They know there's something wrong with them, and this test is giving them the answer. You know, I think it's false hope. And sometimes, we in the last couple episodes we talked about placebo. Sometimes that false hope can help a patient get better. But at the same time, I really don't think there's a lot going on here. So I'm going to wrap it up with that and not just keep droning on. I just, wanted to give you kind of my opinion on these tests, what I think might be useful from them, what's not, and kind of some of the things you might see on there and what you might be able to gather, good information from and not good information from, and how you might be able to use that information to help your patients. So I hope that was helpful. And on the next episode, I'm going to be going through the medication treatment course. So basically, we've talked about the drug, we've talked about depression, we've talked about all the meds, we've talked about how to, all these aspects of how to use them. But let's go through the life cycle of that. Let's talk about, how do we start it? How do we continue it? How do we maintain it? How do we stop it? How does that whole process work? And what's the best way to go about it to get the best result for the patient? That's what we're going to be talking about next time. So I want to thank you so much for tuning in to today's episode. Please rate, like, tell everyone you know that it's a great podcast, and I will see you next time.
There's a devil in my DNA.